Yeah, looking forward to the holiday to be over.
That is true as well. So today we're going to cover the training syllabus. I know that this was a real big request for everybody, and I wanted to wait a little while until I got all the information up. I just finished it this morning, so we'll review that in detail briefly. So before I begin, are there any specifics that you want covered immediately based on what you reviewed in the training syllabus? Oh, all right. Was everything pretty clear?
It is if we can find the information.
Mm-hmm.
The one thing that I'm curious about is, and this was under your training checklist, not necessarily the syllabus, is
right.
the Cal Medi, you know, under the insurances. Not every area of the country has the same insurances.
Correct. Yeah, if it doesn't apply to the area that you're in, like for example, I was saying earlier that I was just up in Seattle, and they have absolutely nothing to do with Medi, so it's just something that I crossed off because there was no point training it because they're not going to use it.
Yeah, is it okay if we kind of edit the checklist to our region? Like, I know the reverse networks, I don't know about everybody else, but we use Epic, Hearing Planet, and HearPO. We don't use those other two that were on there, and HearPO wasn't even listed.
And I think they're working on a contract for Here in America, is what I heard. Here in America is working with Connect to be on board.
That would be good.
I think.
And I know that the checklist was very repetitive. I don't know, is it like different aspects of the topics that it's covered in different sections, or what? Because I know like it would say like insurance here, insurance there, paperwork here, paperwork there, like under different titles, I guess, different sections.
All right, let me see if I can pull up the one that we're talking about here. And I don't think it's this one. Not this one. We'll cover that in a second, so I'll find that myself.
Has more like an orientation feel to it.
Yeah, I know which one you're talking about. I have to go to my email. I know exactly what that one is. How about this one?
Yeah,
Mm-hmm.
that's the one.
Mm-hmm.
Let me shrink this so it's a little more manageable to read. That's still okay?
Mm-hmm.
Okay. So yeah, we'll discuss this one first. There's a lot of repetitive things in here, and there are some things that you're not necessarily going to have to deal with. Like this whole IT department here, you'll never have to deal with that. That's all stuff done by IT.
I mean, I understand showing them how to create a ticket and whatnot.
Right.
But I know it says email there and email somewhere else.
So we have the reverse network that's listed here. The insurance aspects, these are just broken out. Like we said, the Medi-Cal and Medi, that's region specific, so if you don't cover it, you don't need to worry about it. Kind of the same thing with Oracle as well. If you don't use Oracle, then there's no reason for you to cover it because there's no point for them to know it. Submission of paperwork to corporate, and then the different paperwork here, so chart format forms, copies of insurance cards. I understand that's a little bit repetitive, but it really just wants to make sure that it hammers home that all of these things are being covered, like reverse network is here as was covered up over here.
Mm-hmm.
So if you see it mentioned more than once, it's something to focus on. So like we have Carago tickets here. I know that one was listed already above in the IT section. It's things that they absolutely must know how to do in order to perform their job correctly. So if they don't know how to put in a service ticket, it's going to make things very, very difficult. So when you're going through this, you want to make sure that you emphasize this is the appropriate process to do this. It should be made clear, though, for sure. And I will make a note to make this look a little more pretty. This is a legacy document that we have that we've been running off of for our training at the moment. This one here. What did you say about here, Pio?
I was going to say it's a big one we use, and it's an online one that the HCPs have access to for pricing and, you know, to get our purchase order number. So that's a big one to add to the reverse network. I don't know about everybody else.
And I haven't even heard of Astrum before.
Yeah, and I haven't heard of Astrum.
And I know we're not currently contracted with here in America, at least not here.
Yeah, they're working on it. And what about Here USA?
I don't know. We don't use that one here.
We use them a lot also. But I don't think we're contracted with them yet. We were.
Yeah, I mean, I can definitely add those to the list. I'm glad you brought that up. Like I said, it's I'm not trying to pass the buck here, but it's a legacy document. But the more applicable that I can make it, and I can get a nice updated version out to you, probably, let me think, would by class next week be okay?
Sounds good.
Oh, after the holiday.
Yeah, really.
Anthony, yeah, it's nothing that pressing. That can't wait till the real year.
Yeah, but you guys are,
you know, they're going to be
rocking. I got to make sure
us.
You're happy.
Yeah, they're going to, oh, we're happy. They're going to be rocking us to close out the month and get the fittings in and these last few days. Yeah, we're going to be under the gun to get evals in and closed out and trials converted and inventory done. And
it's a short week this week, so we got to do as much work every day.
And still meet the same numbers.
Yep.
Your 25, your 25, your 10 on your performance data report, right? Is that right?
Yeah.
I was hoping somebody would say no.
I know. Over here, Jennifer Vargas, when she sent out the RNS lists, it was 25 for this week and next week. So I'm not sure.
Okay, that makes more sense.
You might want to double check with whoever your
RD.
Well, Jennifer Vargas is like operations, kind of, like your regional person.
That would be that would be Lauren Pajak for me.
I would check with them.
Okay, we might have to do 25 or all those performance data stuff on you for the 4 days, not for those 2 days.
I don't know what's coming out.
The performance data sheet, the compliance, the 25 to 25 calls, the RPOE calls.
As far as I'm aware, they still want them.
They still want 25 just for 2 days?
I would think so. I haven't heard otherwise, but Harshal is my RD, so I'll have to ask him.
Okay. Would the operations person be the go-to then, or the RD?
I would go through the ops coordinator. Susan, if you want to just head that up, would you send an email off to Lauren?
I will, Anthony. I sure will.
Then,
I'll find out for you, and then I'll let the rest of the girls know.
I was going to say, yeah, just CC all of us on it so we know what the plan is.
Okay. If it's, hold on just a second, guys. I'm sorry.
We have filled this chart.
Is it up in the?
We got an email from our RD this morning that we have to make those goals no matter whether it's a 2-day week or a 5-day week.
25 calls in 2 days?
Well,
or
it's
25 calls in.
We're supposed to be open Friday.
In 4 days. Yeah, that's true. That's true. Some centers are open Friday.
Yeah, we're open Friday.
Ouch.
Well, my HCP won't be here, but I will.
Yeah, a lot of HCPs aren't in.
Just send off an email and see what kind of comes up from that.
Okay.
So we can make sure that everybody is coordinated across, because it seems like at the moment it might just be RD specific on whether or not they want you to do it or whether they don't want you to do it.
Okay.
But one thing that I do want to make sure that I highlight here is this hands-on, the day in the life of. These are the big things that we need to make sure that we focus a good amount of time on when we have them inside at your clinic location. So how to schedule patients, how to take care of everything. Thanks, Danielle. It is RD specific, so if you have any questions on how you should be inputting or on what you're responsible for the RNS or patient upgrades, send an email off to your regional director, and they will let you know what's going on.
Okay, so that's easy enough, so I don't have to worry about it. Just everybody check with their RD.
Yep.
Okay, great, Anthony. Thank you so much.
Sure, thanks. Thanks, Danielle. So back to this, make sure that these aspects here, they absolutely know how to do. Because really when you look at it, this is about probably 90% of 85, 80, 90% of what you're going to be focusing on when you're in the clinic on a given day. Is that right?
I agree.
Anybody else? Is there anything that's missing from here that you feel should be added?
No, I think that's pretty good. Maybe phone etiquette, but.
Okay.
Would it be like an overview? Wouldn't your RPOEs be in here for your daily kind of in the?
Yeah, that might be a good addition.
Call. Your RPOE or RNS calls. I guess we don't. The RNS or the tested not sold is that the HCP's duty?
It is, but my RD says if the HCP doesn't get them all done, we have to help them out so the goals are met.
We don't have I don't have any upgrade calls, so I do RNS calls for one of my offices that doesn't have an HCP.
Okay, so that would be a good one to add, RNS, RPOE calls to the daily.
Refer a friend, all the RPOE stuff.
Yep, I'll make sure that gets added to the list. I'm not.
And I think it would also be important for. I don't think I saw in there like invoicing, like if PCC sells some batteries or something. They need to know how to do that.
All right.
Well, it has the hearing aid orders and repairs, but
yeah, I think on there
it's
just added, sales in general.
That's fine.
General sales.
We can call that out specifically. I mean, there's no reason that we can't. And just so you know, I'm keeping paper track of these right now. That's why they're not getting added on at the moment. Did I send you this checklist?
Yes.
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 Okay. And this one's a little bit more general as opposed to working in the system. It's more working in the clinic. Did you notice anything in this one that either shouldn't be there, isn't terribly important?
I was wondering about the send daily deposit confirmation, scan previous day's deposit receipt. I've never heard of that. Is that just for like training purposes or what?
No, we're supposed to send the daily deposit receipts, a confirmation deposit, after we go to the bank. That's in the accounting SOP.
Okay.
Right, but also it's kind of confusing with the. It has a couple. It tells a couple different ways when to send the.
Yeah, I see what you're saying.
When to do your end of the day.
Yeah, I was looking in
and
SOPs and I could not find where it said to send in a copy of your receipt. And I don't think anyone in my region does that. So I was wanting to know about that.
Is that your bank deposit slip you're talking about?
That's
that's what it says. Scan previous day's deposit receipt. And I haven't heard of at least anyone in my area, and I was looking at SOPs and I couldn't find anything where it said to actually scan the receipt in and send it, because they usually email me if they have any questions.
Yeah, are you using the new spreadsheet for the end of the day?
We are using the new daily reports now.
You are. You're using the new daily report, because I think what that means, once you reach over $500, it tells you that you need to do a deposit.
And you have to at least do 2 deposits a week.
Yeah, and when you get that deposit done and the bank, the ATM gives you a receipt, that's what you would scan and fax or scan and email in the following day.
So are we supposed to send that to daily report?
Yeah, goes to daily report, and it's just, we usually just put our US 10002 and then the date it went in, and then deposit confirmation.
Okay.
And then you attach that.
Can somebody email out the SOP for that? Because I was looking and I cannot find it.
Yeah, I don't know if there's a specific SOP for that. I know that was rolled out to maybe not even all the clinics yet.
It's in 10.02.
Thank you. I was just going to look that up for us.
That's what I was. I saw you switching screens.
All right. Nice job.
So back
on
to
that
the,
one.
how about back to the end of the day, the daily report for the deposit. In a couple different places, it'll say go at the end of the day or go after you've closed the office.
That's what we do. Oh, well, our bank's right around the corner. Right after we close, I just go right by and deposit it.
So then the deposit could never be sent in the same day. It's always sent in the next day.
That's what we do.
No. Yeah, I used to do that.
I think every clinic's a little
Everybody
different.
does?
Yeah. I'm not sure this season. I was told not to do it off the clock, but it was much more convenient because the bank was on my way home. Sometimes I would even do it on Saturday.
Yeah, I do mine on the way home just because it's on my way home. It takes 2
Just because
seconds.
it's easier.
I don't want to leave the office midday just to go there and come back. So
exactly.
Probably
That's
every
kinda
clinic's different.
Yeah, it's hard to leave in the middle of the business day to do the deposit. Easier on the way home.
Yeah, depending
Right,
on
but
where
there
you're
was some
located.
controversy that it should have been, it should be done on Connect's time.
I know. That's what I got. Kind of caught it for
And
a little bit.
I think also in that SOP, it says, whatever the RD and the PCC has worked out.
So the new ones, they're all going to end up in the extra one. So eventually all the old ones are going to get to the but if they're duplicating it, they're not. Like they're not updating it.
Oh, I can't understand.
I can't understand either.
It's breaking up really bad.
What's that?
A cell phone, maybe?
Who's breaking up? Is it me?
It sounded like she was underwater when she was talking about the deposit confirmation.
Oh, I don't know. It sounded fine.
Yeah, I couldn't hear. I couldn't understand her.
I couldn't understand her either. I have clinics that the bank really isn't on their way home, but they also have other personnel in the office, so they just let somebody know that, hey, I'm going to do a bank run right now.
Mm-hmm.
The phones do get answered, or, you just set it on your answering system, and you call people back as soon as you get back.
And even hang a sign on the door, went to the bank, be right back.
Exactly. And that way it is done on Connect time, and you're not walking out the door with Connect's money, or you don't take those forms home that have the account numbers and things like that on them. Everything stays within the business atmosphere.
And I was, kind of caught it for doing it after work. So maybe it's the RD that decides because she wants us to do it while we're on the clock during the day in the office.
Right. And that's where the SOP comes in, that it has to be done before, if it's done for the previous day, it has to be done before 1 o'clock, and the confirmation deposit has to be emailed before 1 o'clock. So it would be like first thing when you get there in the morning, you'd set everything up and then just tell your HCP, hey, I have to go to the bank.
Mm-hmm. Try to do it maybe in between appointments or, right as she starts maybe a fitting or he or she starts an eval. That way, you might not have a walk-in, but we've got constant traffic. It's really, I'm bound to miss somebody. Yeah. So if you let the HCP know that you're stepping out, maybe you can decide to put a note on the door or hang a note on the desk, saying be right back so she's aware. But a lot of times the door will be closed for the evals. And somebody will be walking in the office up front, and if you've got anything up front, you don't want it to grow legs. The best thing to do is lock the door and leave a sign, went to the bank, be right back, and then the HCP's aware, back there with their patient doing whatever, the door's locked, and, there's a note saying it just takes me a few minutes. It depends on where the bank is, I guess, how long you're going to be gone, but back in 20 minutes or something.
Yeah, I'm looking at the SOP because I was trying to find the where that receipt thing is. But on the general deposit information, it says either that, but it also says, which I haven't heard of anybody actually doing, but it says the RD must designate the employees who will be responsible for making bank deposits, and it says calculation and reimbursement for mileage and or work time is determined by policies established by Connect Human Resource Department. The RD is responsible for coordinating the assigned employee's work schedule and for understanding and complying with all compensation policies.
And I do put in my mileage for going to the bank. I save it up usually for the week and then submit it. And you should be compensated for that mileage is how we've done it.
I agree.
because I get probably a good 4 to 5 miles, probably 2 to 3 times a week.
Yeah, it adds up. I mean, definitely.
My thing's like literally almost next door. I mean, it wouldn't. I don't know if it'd be worth anything. I'd be like, what, half a mile
Put that
away?
pedometer on, girl, and go walk.
I know, just walk there.
And that'll be considered a good thing for the employee health wellness daily step thing.
All right. And you guys are on the ball today. This is good.
I was going to say, we are. This is great.
Everybody had a little bit of coffee this morning.
Oh no, I don't drink coffee.
We're all looking forward to the long weekend, the holiday.
That's true.
All
right.
Yeah.
How else are we looking on this list here? The one I have pulled up on the screen right now. The start of the day, throughout the day, and at this day.
I got a question about the voicemail.
Yeah.
I know some clinics, and maybe it again is dependent on who and where you are, some people use a call-in, like our Claremont office, and we're not that far from that, Tavares. Here in Orlando, we have, Tavares in Orlando have a regular answering machine we have like at your home, and then Claremont actually dials in, Anthony, I think it's Granite, puts in the phone number and accesses her email through the Granite phone system.
Right, that's the ones that have been converted to the Granite is our carrier for our internet and phone system, if they've come into your office and converted it already. But
yeah, we have a phone with a voicemail on each of ours in our region. I guess that one's something that just varies.
Yeah,
so it's not, we don't, I'm sorry.
No, you're fine. It's a big thing that I want to point out is that these lists are not all encompassing. They're designed to kind of hit that 90% mark. So there's going to be a few things that are going to be outside of the range, and somebody might not cover it, or somebody will cover it, or it'll be completely different than what we're looking at. But we wanted to try and hit the most that we could with as broad of a stroke as we could. So, for example, with that voicemail, you'd have a different set of training that you'd have to do for an office if you had somebody that was using that. Whereas opposed to most everybody else that's out there, they wouldn't even know it existed unless you brought it up.
True.
Which is okay. I mean, it's definitely good to be aware of that, and if that's something that I need to develop and put out information on, then we can talk about that via email or something. But as opposed to all of us, I don't know if that's something that's necessarily applicable. All of us as a whole, I mean.
Right, and I think the new offices or the converted offices anywhere where you have changed, in with that initial email for new PCC hires, the passwords and voicemail and new fax systems, that would all be included with that onboarding sheet. With the instructions.
I got a quick question, kind of off the beaten path, about RPOEs. Anybody game? When we schedule them for their RPOE, it's a 3+, means they haven't purchased within 3 years. And say they came in, they had their hearing test, they maybe tried trials or didn't. When they call back again, if I remember right, Pascal, or our regional VP said to reschedule them again as a 3+ eval, even though they really didn't want to try trials, or they did and they didn't like. So if they call back and they want to have their hearing aids checked again, that they're the old ones, do we schedule them again as another 3+ because it applies even though they were just in, or not?
Yes.
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 You keep doing it
if they have, until they purchase, or because they say every time that they come in, your HCP can still mention to them the new products and see if they can help them in any other way.
Sales opportunity.
Every time will be, so it should be that.
Yep.
Okay, that's what I thought, because I'm running into a little bit of a problem with that one. Sure how to handle it.
But question, you wouldn't necessarily put 75 minutes on that, right?
You can shorten it to an hour.
Okay.
That was a good question, yeah.
But the other thing I do is I always put in notes, was tested on such and such a date.
Or did trials, didn't like, just needs a hearing aid check, but needs to be scheduled as a 3+.
Right.
Okay.
Okay.
And another question to clarify, and I'm pretty sure that I looked in the SOPs on this one, the DSBs are what they are, those set times from 8:30 to 9:45, 9:45 to 11, and then of course we roll into, then we got, the lunch hour, 12:15 to 12:45. Next one, 12:45 to 1. We have that little 30-minute window, like when Pascal calls, it doesn't run in, or we have the vice president call, he's got that block, but then they got the 3 set in the afternoon also. Starting again at the, I think it's 1:15 to 2:30, and then the 3:45, et cetera, down the line. They're all, it is what it is that right?
Yeah, well, with the extreme dedicated schedule blocks, it really kind of varies. I know RRD, let it vary because some of our providers, at least in our region, a lot of them prefer 90-minute evals as opposed to 75. I know my HCP does. And so they had all the PCCs set up regarding what the provider wants. So if it's 75, there's like 6 DSBs throughout the day. Oh. And if they're 90-minute, then there's 5 DSBs throughout the day. And it does vary, the little time difference and whatnot for like the little break in the middle of the day. But, you don't want to, like what our RRD, when we're talking to him, we don't want to give 75 minutes when it's going to make everything run behind the whole day.
Right. See, I'm getting that ours is written in stone. This is how it's going to be, and this is from the vice president now. This is from Pascal, not from my director. It's from her boss, from my director's boss. Said this is how we want our schedule set up. Period.
Well, I think with Jonathan and Mitch, our vice president, I don't think they've
now Mitch Biggs is above my vice president.
Yeah,
Mitch
he's actually RRD right now because Jonathan just left. But we haven't had any issues with that.
So you can have a little flexibility depending on the clinic is okay.
It's still set in stone that we have those extreme DSBs, but we have 90-minute ones because my HCP and many of the HCPs in my region need 90 minutes for
and the times don't have to be starting right at 8:30. They could start at 9 if your provider wanted it to.
Well, no, still it needs to start at the beginning of the day. Like for the SOP, it starts at the beginning of the day, and at the end of the day, the last eval should be, and that middle time should be, 11:30 to 12:30 is what we have. Or I think if you have 75 minutes, it's like 11:45 to 12, something like that.
And then your lunch, you're not locked in with that. You can vary from 12:15 to 12:45 or say 12:30 to 1.
Yeah, we really do, and especially because we have those weekly calls.
Yeah,
and on that day, we kind of change it up sometimes just because, we have to work with what we got.
Right. You got to kind of overlap them and make it work. Exactly. That's why we did ours when Pascal, like our VP does his regional call, he'll do it 12 to 1. So it works out. If we go to lunch 12:15 to 12:45, we still have that last time block, that 30 minutes we have from 12:45 to 1:15 before the next DSB starts at 1:15 to complete his whole hour call.
Yeah, so it all kind of varies. And the call, so like our calls right now have been like half an hour. And, they've been trying to fit it in during that time, but, sometimes they want to do it from like 12:15 to 12:45 or something, which interferes with our schedule block, but, it's just what it is,
Yeah, we kind of have to go with it. Yep.
You just got to go with the flow and kind of schedule around it and fix it up how you can.
Yeah. I just didn't know if everybody was locked into that same lunch and the same times for those extreme DSPs.
Yeah, I know we have our 75-minute offices. They're going to lunch like at a certain time pretty much. But then we've kept ours from 12 to 12:30 for the HCP because we're doing the 90-minute, and that fits in perfectly with our schedule.
Yeah, I can see, yep, definitely with the 90 versus the 75.
Yeah, and it just wouldn't, since we have the 90-minute, it wouldn't make sense to put it in the other spot because then that would cut into the DSB.
Yep,
so.
It would, yep. So depending, like we do 75, so that works for the 12:15 to 12:45 for us. Yep, got it.
But if you needed to, you could do the 90. According to whatever your HCP requires.
Yeah, like my HCP, she needs 90 minutes. If we do 75, we're going to be, especially if we're booked all day, we're going to be
behind.
You're way too late.
Yeah, yeah. See, now the other one where I work is another office where I'm at most of the time is he'll get them done in 60.
Oh, wow.
And then we got another provider in another office that'll do 2 to 3 in 60 minutes.
Wow.
It's crazy. That's why he's at the top of the list of his units. Yeah, I'm like, dude, how do you do that? Oh, 4 patients in an hour. That's why.
So how would you end up trying to explain this to a brand new PCC?
I think it's really a matter of explaining the HCP PCC relationship. You know, you really have to communicate with your HCP and find out what is comfortable for them, because you don't want to give them, like, you know, the HCP is used to having shorter evals, well, you need to talk to them and find out what they're comfortable with. If they're longer, you know, you don't want to schedule it inappropriately.
I think the biggest stumbling block is you're talking to somebody who's brand new in this environment, and they may be afraid to ask too many questions. They may think they're bugging the HCP or whatever, and you just have to, you know, make them comfortable with the fact that, you know, the stupid question is the one you don't ask. You know,
I think as a trainer, the first day, it would be we would talk to the HCP and the PCC at the same time,
together
to know each other and say, okay, this is what I'm going to need from the HCP so I can continue the training with the PCC and about the dedicated schedule blocks.
Exactly, and you know, with the new PCC, with the new PCC, that those extreme DSBs are probably already set up in that schedule for the HCP.
Right.
So you know, you're probably already going to have an idea of
what you're going to be doing every day. This is what it's going to be for this clinic. This is what it's going to be for you as a PCC in this clinic. Because the HCP will probably already have that established. Maybe just confirm, you know, this is how you have your schedule. This is how where your lunch hour will be or your lunch half hour will be, and then that's what it is. What it is.
And then, you know, with the lunch, of course, we're doing. I know we're supposed to be doing the staggering now. I know my RD before and whatnot said it's okay as long as you leave the door open. You know, you can kind of go to lunch together as long as somebody will watch the phones and the door, as long as there's somebody in the office.
Like one go for 12:15 to 12:45. The next one 12:45 to 1:15.
Right.
Okay, somebody's having too much fun.
Yeah, it's my neighbor. Sorry.
Got to do something to keep warm.
Okay, I got a question on the schedule for the day. How many of you in your offices check the newspaper for the obituaries for current patients that have passed?
I don't, but you know, when we're doing RPOE and whatnot, if you can't get a hold of a patient or whatnot, you can go to legacy.com and look up the obituaries for the area.
Right,
We've done that before.
when we get mail returned, if they have no contact phone number and if you get the mail returned, that's when we go to the obits.
Yep.
Do you guys get a newspaper every day? Ours was cut off, so we
don't get a newspaper.
No, we look it up online.
See, some of our clinics still get a newspaper every day,
I wish
and that could be because that was a legacy thing. That was what we were doing before Connect purchased us, and that has never been discontinued. So, you know, if we get the newspaper every day, we look, you know, go through the obits, just type in, do they pop up?
Yeah, see, I go to the legacy.com. We've never got the newspaper here, but
so we can find all obits on legacy.com, even for like.
If you click obituaries, you can go to the state, and you can do through all time, and just type in the name, and then you can also, if it doesn't pop up in the obits, it has like the Social Security index, and you can click over to that and check that index too.
Now we don't get the Social Security numbers like we used to.
No, but it doesn't require the Social Security number, just the name,
date of birth.
It's kind of like when the death certificate was filed, so it's on that separate record, but there may not have necessarily been an obituary.
Yeah, ours we have snowbirds with northern addresses, kind of throws us off. Oh, I'm sorry, Margaret. I'm sorry. Go ahead.
No, this was Gail.
Okay.
I use the SSDI a lot, but it will not show anybody that's died within the last 3 years. So, you know, I've had the best luck just going to Bing or whatever and typing in obituary for first name, last name, and the last city that they lived in.
Looking specifically for that patient.
Looking specifically for that patient. The thing I was talking about was part of our daily tasks
as that on the
newspaper when we're opening up the office is to just scan those obits, to go through them and find anybody that was a current patient before we end up finding them doing our RPOE calls. You know, catch them now if they died yesterday or last week.
If you recognize the name.
So that we don't run into them on our call list later on.
Yeah, I mean, if you get the newspaper at your office, I'd most definitely do that. I mean, we never got it over here, and I don't get it at home either.
And a new PCC won't recognize the names in the paper either.
That would be kind of tedious.
Yeah.
Yeah, I think that's more the added work that we don't need.
That is a lot of added work because we've got pages and pages of obits in our local paper. You could be there for a long time looking through each one.
I suppose it depends on the area you live in. I've been in some where there's maybe 5 names.
Yeah, so if you're in a bigger area, like I'm in San Antonio, so you know we've got millions of people in the city.
Orlando, and it's
easier for you to do it online if you get their return mail and don't have a current phone number.
Yeah, I agree. I agree.
Good trick. I'll go ahead and add that information because I think it's worthwhile to address if we're talking about RPOEs, and instead of
kind of ties in with daily work as well as your RPOEs, RNS.
Yeah, I mean it's another trick. I mean, just not because you know, somebody decides that they want to try it and see what happens, and it's worth giving it a call. Any other questions that we have on this on the checklist here? I think we pretty much covered everything.
I think so.
It all looks good.
Oh,
right?
there is one thing I have. Okay, so it says, let's say an office opens at 8 o'clock.
Okay.
And they want you to check in at 8 o'clock. I think on the start of the day, because I tell the PCCs to be there at least 10 minutes ahead of time. So they can clock in, they can make sure their office is tidy and neat, and be ready by 8 o'clock. Not just get there at 8 o'clock and then have
a patient at 8 o'clock.
Right.
That's the problem we run into here because the patients are scheduled for 8:30, and if they're a new patient that I haven't been able to, say, mail the paperwork ahead to, if I have 3 to 4 days or 3 to 5 days, I'll mail the paperwork, but if they come in early at 8:15, we should punch in, right?
Yeah.
That's what
I think that should also be on this PCC daily checklist, the time to clock in, that we don't want you there at 8 o'clock. We want you there before 8 o'clock so you're ready to work at 8 o'clock.
Because you know the patients are going to be here before that first time.
All right, so then what do you do if you're punching in 15 minutes early every day, you end up with all this overtime at the end of the week, and your RD's calling you up going, hey, where's your schedule management for your time?
That's the question. You
know,
when we end up with the overtime, what happens?
Our RD said that we can clock in 10 to 7 minutes before, and I think it does have to be brought up to the RDs and the Vice President Pascal, because I wouldn't expect anybody to come in 15 minutes early and work on their own time.
Right.
I would want them to be there 10 to 15 minutes early so they can make sure that they're ready for that first appointment that may get there at 15 minutes too to fill in his paperwork. So I think that not only has to be addressed with our PCCs, but, you know, with our higher-ups
the VPs, RDs, VPs, because we can't come in at 8:30 and expect the patient work to be early and fill out paperwork, and then they do not want us working off the clock.
Right.
That's a big no-no. So we have to punch in at 8:15.
What we do here, this is Stacy in Tacoma, is our RD put blocks in for our clinic doesn't open until 8:30, but we don't see our first patient until 9.
See, that's what they wanted to do here in Orlando.
Yeah, because you can't have your patient sitting outside waiting.
Okay, so your clinic, what is your clinic hours? From 8:30
to 5.
8:30 to 5. So.
Oh no, 9 to 5. My hours are 8:35, but 9 to 5 are our clinic hours.
So how do you do your DSB?
How do you do your DSB?
At 8:30.
We
Yeah,
don't start them
start
until
at
9
8:30.
o'clock, and then we do 90-minute blocks.
Oh, okay, that's why.
Mm-hmm.
But most of ours in this region do have a half-hour paperwork slot. Get ready.
See, that's what the HCP would like here. She wants to start at 9, but they're telling us we have to start at 8:30.
Yeah, that's what we were told too.
Who is the one that who just said that they clock in at
Susan.
8:30, but they're first? Susan? And what region are you in, Susan?
Oh no, I'm
Stacey,
sorry.
we're in region
That was
109.
Stacey. Oh, starting at 9. I start my patients at 8:30.
Yeah, in our times are a little bit different throughout ours. Some of them start at 8, but they don't see their patient until 8:30. So each of our clinics has different hours.
I have a
So your
completely,
CVS would start at 9 o'clock if you were in 8:30 office?
Yes.
I have a completely different scenario. Our office in Denver starts at 8 and goes to 5. I get here at 7:45 and clock in, and then I leave at 4:45 and clock out. We have an hour for lunch.
Wow.
And our blocks for our HCPs start at 8.
Wow, I'd like an hour for lunch.
Yeah.
Who's your VP?
Yeah, we start early. We start seeing patients at 8.
I wouldn't mind coming in early to leave
here
early.
in Georgia too. We have various clinics that open at 8 or 8:30.
Well, and ours is
9.
because of when we were Aspen Hearing Center, those were our hours. So we were told to keep our hours.
Yeah, I think everything just depends on what you used to be. Like Jones, I think we're all 8:30 to 5. And so that's just what everybody is over here.
All of us.
So
here.
when do you clock in at?
Quick,
I usually clock in between 8:24 and 8:30 because I've noticed the time schedule here is similar to when I worked at the hospital, towards that 15-minute blocks. And so if you clock in at 8:24, it's still going to clock you in at 8:30.
That's 6 minutes.
So you're on the clock.
True. That's true. They do it in quarter increments.
Yeah, so I just make sure I clock in at 8:24 to 8:30.
Is that for your
and
8:30
start my
for
work.
patients too? How about if they're coming early to do paperwork? Do you
I mean,
still wait?
if somebody by chance gets here early, and then I'll clock in early to help them. But usually, I mean, that happens once in a while, but usually not.
Not a
usually
lot.
don't have someone come in that early.
Right, not a lot.
I think it's more of an exceptional rule. You know,
Hey, Katie.
patients come first, but, you know.
Let me go ahead and jump in here. Susan, hang on. This seems like it's very regional specific on how your RD wants to address it. So instead of trying to hash out and see how we're doing it in every other region, I would recommend if you have any questions on what you should be doing, contact your RD. And this information that you're going to end up getting, it's a good conversation to have because you're going to be disseminating this to your PCC. So you absolutely have to know on the exact process that you should be using in order to teach that. So
Confirm
I think
with,
it's a good conversation. Yeah, confirm with your RD. And I can, if you want, this is something that I can handle. I can reach out to the RDs and Pascal and Mitch and figure out exactly what they want to be done.
I guess Anthony, the time that would be like, to confirm would be our clinic times, our lunch times, half hour, and do we punch in early if we have an 8:30 patient, a new patient coming in? Is it okay to punch in before 8:30 when the patient's told to come early, say for paperwork, a new patient?
Okay. Yeah, I can take care of that. I'll send out an email, and then once I get a response, I'll forward it off to you.
And, are the DSBs flexible for everybody, or are we all supposed, or is it region-specific or clinic-specific?
With DSBs, you either have 5 or 6. There's no variation. You either have 5 of them or 6 of them on the schedule. Depending
But it depends on the HCP.
Or 90.
See, I keep getting this, it depends on the HCP. See, ours for our area, it is what it is. We start at 8:30, next one 9:45. The next one 11:30, then we start again, at the 12:45, et cetera, at the 3:45 through the afternoon. I'm sorry, 2:30 to 3:45, 3:45 to 5. We always have that same, no matter what clinic. So.
Well, our HCPs here in
Okay,
this whole region.
I'm sorry. Stacy, I don't mean to cut you off here, but we actually need to kind of get on track on this. Like I said, I'll send off an email and figure out exactly what we need to be doing and get your response back from your RD. But we only have 11 minutes left, and I want to make sure that we can get through this last little bit. Yeah, sure, absolutely. You can go home. Take the rest of the week off. All right, so
we're going to hold you to that.
Yeah, absolutely. I get to tell everyone, just do whatever, it's fine. So we have our PCC training syllabus up over here, and it was the first document that I brought up. And the only question that seems to stem from this is where the information was at, correct?
Yes.
Fantastic. There are a few things that I want to make sure that I highlight that may not necessarily know what I was driving at. So you can look at 445 here, this metacognitive SPCC open-ended questions. I know that you get the open-ended questions here, but the design for this extra 15 minutes is really to leave the PCC alone and let them collect their thoughts. There's a lot of information that they're covering on every single day. And if you don't give them time to process what they're thinking, it's not exactly the best way to really try and have them remember information, because they need to be able to draw those connections to everything else that they've been working on. So we need to really just give them time to absorb. And your purpose here is really just it's 15 minutes that's dedicated for you just to sit there, and if they have questions, they ask. If not, just kind of let them be. Kind of a cool down time.
Okay.
I did have a question. What does WI stand for?
Work instruction.
Oh, okay.
So on the clinic operations manual, you have your you know what I'm talking about.
Yeah, I got you. I was looking at it when you first sent it out, and I was like, I don't know what that is. I got you.
Don't feel alone.
No worries at all. Let's see, we have all that stuff. The last day, I want to spend a little bit of time talking about this. This is what you did initially. So we did not do this first portion here, but your review with the PCC on everything that they covered. You already know what's on the test. Yes, there are changes that are being done to it. Don't worry, not a big deal. But you know what's on the test, and you'll take it again before we get out of here. So you'll give them study time, give them time to answer questions, and then the in-person system test, so making sure that they can go through cycle and create an appointment, how to create a new patient, things like that, and then give them the online assessment exam.
Is the online assessment exam like the same thing that we did before we started training?
Mm-hmm.
Okay.
Yeah, same thing. There's absolutely.
They have a cycle that, like a dummy cycle that we can work in?
Yeah, everybody's got a test login, so
I haven't ever done that before.
No, me either. A test login would be great for her to, him or her to make appointments, and like you were just saying, to see how they would be able to do an invoice or.
Yeah, could we
have one? Your test login is your first name, last name _ test, just like regular cycle, and then your same password.
Okay, so you can put your first name last name, and then what was it, _ test?
_ test, and then your same password.
And same password, girl.
And up on your right-hand corner, it will say training cycle.
Okay. In the right-hand corner?
Yep,
so you
that
know
is
you're
absolutely correct.
So you know you're in test mode.
Right.
What does it say, Gail? In the upper right-hand corner, it'll say cycle test?
Cycle training.
Cycle training.
Training
Thank you. Training mode. Thank you. That's hugely helpful.
Yeah, and it's at these exercises and things that we have set up in here. There's no way that you can do the system training without having them have that aspect available to them. So how to go in and enter in discounts on an invoice, how to do actual invoicing and taking payments, for example, returns and exchanges. If they don't have access to a dummy site, all you're doing is just filling them with this information that they have nothing to apply it to.
Exactly.
That's how I was trained as a PCC, so having that dummy site will be very nice.
Yeah, I was trained with just the real thing. I didn't have access to the dummy site at all.
Yeah, it was like if that patient came in and had to do that, then you got lucky and
you got lucky.
See it.
You have to do it that one time, and if you're in a slower clinic, there's a lot of things that you won't get to cover with them if you didn't have access to that.
Most definitely. So yeah, we've got that addressed. Again, it's first name dot last name underscore test, and then your password. So take some time, see if you can log into it. If you have any issues, shoot me an email. We'll figure out what's going on. But there shouldn't be any problem at all trying to get in the cycle.
That'll be a big help.
Let's see. Well, I think that pretty much takes care of the main stuff on the syllabus.
I have a question about the syllabus.
Yeah,
I
what's
see
up?
that it shows 5 days.
Yep.
That would be like heaven to have 5 days to train someone, because we're used to doing it in 2, maybe 1.5.
Oh,
3
no
for
way.
Really?
Uh-huh.
No way. Oh, my gosh. I thought a
So
week
will it
was
be a
tight.
total 5 days?
It is a total of 5 days where the PCC will be in your office.
So we don't go to the PCC.
Nope, they come to you.
Well, and my RD will have me go to the PCC, but much later than when the new PCC trains with me first.
No.
Mm-hmm.
Next door.
Yeah,
Yeah,
I know.
that's different.
When I was
Like-
trained, the person that trained me came down like a month or 2 later when it wasn't really necessary.
And we
Yeah.
took our new PCC and put them in a slower office for them to learn the ropes, and then brought them back to their clinic they'd be working in.
The ideal way that this would work is days 1 through 5, they are sitting in your clinic and really watching you work. There's going to be some tasks that they can do on their own, but we want them to be fully in that experience of, this is how my day-to-day is going to go.
And applying here in their office would be...
Right, that's going to come a little bit later. You will be making visits to their office, how we talked about there being the necessity for 25% travel. This would come later. So within potentially that first month, you'd drop down for a day and say, hey, how are things going? Let's make sure your clinic's up. That's really where we're trying to look at the moment.
And Anthony, I just tried to log in under that dummy cycle, and it won't let me. Should I just email you or email someone about getting access to the test site?
Try this password. Try connect with a capital C.
Okay.
And then the number 1.
Okay.
Hey, Ann, I got a question.
Yeah.
One of your emails mentioned a senior PCC section on My Connect. Is that step? And where is it?
I just put it up.
I think you had a link in one of your emails.
It's in marketing on the left-hand side.
Okay, I was looking everywhere else but there.
Who was that?
That's
Sorry.
Gail. Sorry.
Oh.
Here, let me send you the link, Gail.
Yeah, with that password, it still doesn't work. So I don't know if
Yeah, send me an email. We'll figure out what's going on.
Okay.
Yeah, it's not working.
We'll see. We'll see. We may just have to set you up on our end, and it was never configured. I don't know offhand, but we'll figure it out.
Yeah, sometimes it is not. I've noticed that for training, because sometimes I just use mine and let everybody use mine because they're not set up when
That's
they
what I've been
train.
doing with mine too.
Yep.
All right. So for those of you that have yet to go here, Margaret, I know you have.
Yes.
This is because you like the page. This is all the information that we have set up for our SPCC training classes. So we have week 1 that's on here. We have week 2. These are the recordings that we had. Week 3 will be posted shortly. But beneath those, this is all the new information that I posted up here. So we have our syllabus and curriculum on this side. You can click on those and download them. We have our PowerPoint presentations. So on not that one, yeah, on this one here. So it says there's a PowerPoint presentation, or mainly the PowerPoint presentations. All those are posted up here.
Okay.
And then there's web-based training. This is your homework for next week.
It's next door. You have to go around and tell them to open it. This is not a restaurant.
Anthony.
Sorry.
No problem. So your homework for next week, there's going to be some other stuff, don't worry. It'll be light. The big thing that I want you to do is to look at one example of the web-based training. So there is an instruction manual up here at the top for how to use web-based training. Download that and then pick any one of the ones down here and then view it.
Okay. And that's the homework for next Monday.
That is the homework for next Monday. There might be something else that I'll send out.
Oh, no. Oh, God, don't do that. Please don't ruin our vacation.
It's actually on here. There's this instructional strategies PowerPoint and DocX. This is what I'm going to be covering next week. It's going to give you, it's going to be more focused on training and teaching and giving you different examples and things that you can try when you're working with your PCCs to impart knowledge on them. Take a look at these two. The instructional strategies, it's a really short PowerPoint presentation. There's not a whole lot of meat to it. There's a lot of pictures, so not that big of a deal. The script is where all the information's at. Do not read the entire script. Just kind of leaf through it to give yourself an idea on what we're going to be talking about. So when you show up, you might have some questions. Come with 1 or 2 questions, because that'd be really great. Because the presentation is designed to run about a half hour. So I want to leave a half hour for us to talk about what's going on and how we can actually use this in a real-life situation. So homework again, watch one of the web-based trainings. Actually, if I could suggest one to you, I would say watch the capacity one. Don't stay short. It's only about 5 minutes long.
Not the capacity alone, not capacity demand conversion.
Yeah,
just capacity.
just regular capacity.
Okay.
And then look at the instructional strategies PowerPoint. And I'll send this out into an email once I get the stuff up. But check those 2 out. It'll be short. Shouldn't take any longer than probably about 10 minutes. Hopefully. If you spend longer than 10 minutes, you're doing something wrong.
Either that or we're being very thorough.
That's true, but I mean, then you're taken away from all the fun stuff that they get to tell you about next week.
Then again, you might be taking us away from our family, which will be rescuing us. Some cases.
All right, that's true. You can do that if you'd like. Outside of that, we're good. What questions do you have for me? Is there anything that's sitting out there that we need to make sure we have addressed?
I think I'm good at the moment.
I think, yeah, you guys have really helped me with a couple of mine today.
I have a problem. I don't know if we have enough time for it, but I have had 2 patients call me upset about EOBs that they received. These are insurance patients that the billing department has billed, and they're getting denials on their hearing aids. And
I've had some issues with that too. And
hey, Katie? Hang on 1 second. This is a really, really good question to send out through email, which you guys did a fantastic job doing that, by the way. Really, really good. I'm sorry, I didn't catch you as actually asking that question.
It was Lori.
Hey, Lori. Sorry, because I'm getting good with names, but I'm better with the ones that are actually logged in instead of it saying phone caller. So, Lori, if you could send out your question to our group, so that way we can all answer it.
Lori, what was the full question? Because I kind of want to write it down, too.
Well, I'll email it so we can get off the phone. It'll be a full question on the email.
Perfect. So I can let you guys get back to what you need to do. This is a fantastic class. We got a lot of information covered, which is great. And I don't think anybody was quiet at all, which I like. It's good when people talk.
Yeah, I think we're getting better and better.
You are getting better and better. Absolutely.
We are.
You are fantastic.
Awesome. We are the bomb.
You are. And don't tell them that you're much better than my PM class. So
Woo-woo!
If you got any questions, send them out. Usual jazz. You'll hear from me tomorrow about our session on Monday.
Okie dokie.
All righty,
Otherwise,
ladies.
have a happy holiday. Enjoy yourselves.
Merry Christmas, everybody.
Merry
And a
Christmas.
Happy New Year.
Enjoy your 2 days off.
Yeah, there you go.
All righty.
All right,
All right.
guys.
Take care, everybody.
Take
Have a good
care.
one.
Bye.